All right, looks like the numbers are starting to level off a little bit. So I just like to, in the interest of time, get started here. My name is Matthew Piecha, and I'm with the Center for Practical Bioethics. I would just like to welcome everyone here to the our vaccine webinar series. We're doing this in collaboration with American Public Square. This is the second installment in the series. The third installment will be hosted by American Public Square. It's going to be on April 1st. You can register for that on their website. I also have the registration link. I'll drop that in chat later on. Before we get started, I've just got a couple of other announcements before I hand it off to Terry. We've got another exciting event coming up around this time next week. So on Friday, March 12th, we have a workshop with Dr. Barry Curzon, who is the personal physician to the Dalai Lama. He's going to be doing a workshop on cultivating compassion and meditation and mindfulness. So it's a 2-hour workshop in the afternoon that's free and open to the public. So we would like to welcome you to register for that. You can find that on our events calendar on our webpage. And then also just this the subsequent installments on this series. As I said, April 1st is the next one, and you'll find more information about the rest of that series on our events calendar as well. Couple of housekeeping issues. These sessions are recorded. If you want to review any of the content that you see today or catch up on the back episodes, share them with your colleagues, you can find the recordings on our YouTube channel. That's just go to YouTube and search for Practical Bioethics, and you'll find us there. We've got the back episodes of this series, as well as a number of other COVID and otherwise ethics related content there. So we encourage you to check that out and subscribe to the channel. Then also, we want to keep these sessions discursive. So if you have any questions that come up during the session and you want to ask the speakers, we encourage you to use the Q&A tool, which you'll find in your toolbar down at the bottom of the screen. If you submit questions there, we'll do our best to get to as many of them as we can. If we can't get them or get to them live, we'll see if we can type responses to them as well. So just keep an eye out on that. And with that, I would like to hand it off to Dr. Rosell, who will speak or who will introduce our speakers and the topic today.
Thank you, Matthew. I am Terry Rosell. I serve in the Rosemary Flanagan Chair at the Center for Practical Bioethics. And I too welcome each of you and our guests to this edition of our webinar series on COVID vaccine and ethics. Today, we're talking about the state of the science and the ethics of equitable allocation of vaccine. Our guest panelists and presenters are Dr. Catherine Satterwhite and Mr. Broderick Crawford. Dr. Satterwhite will speak first, followed by Mr. Crawford, and throughout we will leave open the opportunity for conversation. Any of you, as Matthew noted, are invited to post your comments or questions in the Q&A box on Zoom. Dr. Catherine Satterwhite, PhD, is the Regional Health Administrator for the U.S. Department of Health and Human Services, Office of the Assistant Secretary for Health in Region 7. Region 7 comprises Iowa, Kansas, Missouri, and Nebraska. Catherine is the senior federal public health official in the region and has spent the past year focused on what? COVID-19, of course. Mr. Broderick Crawford is president of the NBC Community Development Corporation. He is chair of the University of Kansas Cancer Center Community Advisory Board. He's the principal investigator on an NIH grant and a member of the Wyandotte County Health Equity Task Force. Broderick, in his own words, is dedicated and committed to improving the lives of the underserved, the less fortunate, and communities of color. And I have worked with Broderick enough to know that that is indeed true. So Catherine, I think you have some slides that you're going to share. And we'll look forward to what you have to present. Thank you.
Yes, I do. And hopefully you can see them.
We can.
And you can hear me.
And we can hear you. Thanks.
Fantastic. Thank you for the great introduction and welcome to everybody on the line. Broderick and I met a few days ago and I feel like we're already best friends. So Broderick, at any point, if you want to jump in while I'm speaking, please do so and we can keep this conversational. So I do want to start off though, before we start talking about vaccines, because I think framing is really important. So we are not in a horrible place right now, relatively speaking, but there is still a lot of disease circulating. The virus is still out there. So while we are in a very optimistic place, I just want to remind everybody that until you get your vaccine, which I encourage you to get whenever you're eligible, don't forget to do the things that have really helped us a lot in this pandemic, maybe not as much as we would have always hoped the entire time, but please continue to wear a mask, stay 6 feet apart from people, and avoid crowds. I do know that the CDC is working on language that will adapt to the situation that we're in. So as more people get vaccinated, we really hope that we might be able to change some of this. But for now, keep doing the things, even though I know everybody's tired of it. They are still very important.
So Dr. Satterwhite,
yeah.
if you could go back to the previous slide, and first of all, thank you again, Dr. Rosell and the Center for Bioethics for allowing me to speak as well. And yes, I agree with Dr. Satterwhite. We've only met just briefly, but yes, I think we are fast friends. And so as we look at the slide and as we have certain groups or individuals who have been fortunate enough to get the vaccine, one of the things that often comes up is, now that I've had the vaccine, do I still have to do this? And so one of the things that I think is very important for us to continue to emphasize and advocate is that even though you have gotten your vaccine, you still need to wear a mask. You still need to stay 6 feet apart, and you still want to avoid crowds, because even though you may have the vaccine, there are still some indications that things can still be passed even though you've been vaccinated. So if you would, from your point of view, speak to that, particularly for this group, because I think that is so important.
I agree 100%. And the reason, it's one of the reasons why I put this first. So right now we are still in a supply and demand issue for vaccine availability. And we know that we've come a long way and now is not the time to let up. There are people who are doing really important work to look at the true full vaccine impact. But right now, the data that we have definitely say that the vaccine is amazing for protecting from severe disease. So when you're worried about getting really sick and going into the hospital. But we also are looking at data to show how the vaccine impacts transmission of the actual virus that causes disease. And while we're waiting for those data and while we're waiting for more people to get vaccinated, absolutely, we have to continue to do these things, even if you've already gotten the vaccine, because we would rather keep people safe. We don't want to see a surge again and then have to, really be in a situation where we were earlier. So thank you so much for bringing that up. All right, having said that, I'm going to move on to vaccine now, which is the reason that we're all here, and there's so much to talk about around vaccines. So what I'm showing you here is a message, a social media message or an image that CDC produced, and there are a whole bunch out there. I'm going to describe where you can get those later, but just want to highlight there are all sorts of people working on messaging to help make sure that everybody can get the information they need to make an informed decision, which hopefully leads to them getting vaccinated. So what I want to start by talking about, and again, Broderick and I have talked about this, jump in. We know that while we are in an atmosphere of limited supply, people still may be hesitant to receive the COVID-19 vaccine, even if they have access to it. So there are a couple of things that really are things that people think about. Are there side effects? Does it work? Is it safe? How much does it cost? So I'm going to talk about a few of those things in my slides and in conversation with Broderick as we go on. So what I want to start to talk about is actually what we think about when we think about hesitancy. So first of all, it doesn't mean that people are kind of on one end or the other. Yes, we know there are some people who are, yes, I want it and I want it right now. But then there are other people who are like, no, I don't want it. I never am going to get it. But a lot of people are in the middle. They're in this place where they kind of want to wait and see, or they want more information. They have questions, and it's normal to have questions. It's healthy to have questions. And what we want to make sure from a federal government perspective and a community and societal perspective is that we take the time to answer questions that people have because they're valid and they're important.
And Dr. Satterwhite, that is such a very important, and you can stay here at this slide. As we look at one of the things that we're working with, particularly with the RADx NIH grant and with our Health Equity Task Force, is how to address this very slide. You know, I often use my own family, and I have 6 brothers and sisters that are all in different spaces about getting the vaccine. I'm very fortunate that I have gotten both doses, but what we don't want to do is penalize people for having questions. We should not be shaming individuals because they have questions about this vaccine, whether it's questions that goes back to Tuskegee and goes back to J. Marion Sims, who was doing work in women that has many of the tools that we have now for obstetrics and gynecology on enslaved women. All of that is relevant all the way to, you know, I also have 2 sons that are definitely on the opposite side. Dad, I don't need that. I'm healthy. I'll get through it. If I get sick, I'll get well. I'm immune. And so the Superman syndrome. And so we have individuals on both sides. And then without question, our minority community has every right to question what we are presenting. And I say we as the medical community, what we are presenting for them to receive. Because again, there are a number, countless cases of where individuals have been mistreated in 2020. So we don't have to go back to Tuskegee. There are examples in today's medical community of folks of color not being treated fair.
So I want to interject here also, and Catherine, I'm not sure if you will address this issue or not, but it has come to the fore in certain media articles in the last week. It's not new. We've known it was there before and relative to other vaccines as well. But that is the issue of vaccine hesitancy or refusal, not on grounds of Tuskegee or that, but on grounds, religious grounds. Mm-hmm. And so maybe you can talk about that a little bit as well, here or later.
Yeah, I'm not going to specifically address that. However, I am going to pull it back into the all questions are valid, because I think that as a medical community, as a public health community, it's about treating it that way. I mean, people are getting information from a lot of different sources, some of them more accurate than others, but it doesn't mean that any of those questions shouldn't be asked. So whether it's a religious belief, whether it's a historical concern, whatever the case may be, I think we need to make sure we're having a dialogue with people instead of telling people what to do. Even though I really hope that everybody gets to the place where they really want a vaccine, everybody has a right to ask those questions to go on that journey. Which actually, go ahead.
I'm sorry, I was going to say, Dr. Satterwhite, that is so important, that everybody has the right. As Dr. Rosell was saying, even within the Catholic Church, you got the Archdiocese somewhere in the South, I can't remember if it's Louisiana or Texas, but one of those states, who has come out and said something that is totally different from what the Pope has said. And so when you have individuals within an organization that may be saying different things, it creates confusion and adds to that hesitancy. I'll say that we're working with faith leaders here in the greater Kansas City area, both in Kansas City, Missouri, Kansas City, Kansas, Johnson County, where we're trying to get synergy amongst the faith leaders so that their congregations aren't confused. When they're getting mixed signals, it creates confusion. And so we have a tough enough time just dispelling the myths and the fiction that's out there, let alone to have individuals that are leaders of their respective congregations that may be sharing information pro or con. They have every right to, but let it be based on fact and not fiction.
And there's a lot of fiction. I don't know that we want to spend more time on this one, but there actually may be more coherence to the religious argument, basically involving the argument about aborted fetal cells having been utilized in research development testing of some of the vaccines. There may be more coherence between what the Vatican says and what the some of the diocese bishops are saying too, but that may be another whole webinar.
Yeah, I think we could probably spend a good half hour on that one.
Yeah, the point being, there's fiction, there's disinformation, there's misinformation, and then there is just differences of opinion regarding certain sort of dimensions of hesitancy. And I think we need to be addressing all of that. So thank you both.
Absolutely. Dr. Satterwhite, continue, please, ma'am.
Well, I think this sets me up perfectly for here, because a lot of what we're talking about is trust, right? Trust in having that dialogue, and trust in getting the right answers from the people who are the experts. So we know, and this is not just this vaccine, but all vaccines, sort of the number one factor that goes into whether or not somebody gets a vaccine is whether their healthcare provider recommends it and has confidence in it, and then also is willing to engage in that dialogue. And it's not just it's the confidence in providers, but it's also in the processes and policies that led to the development, licensure, and manufacturing of this vaccine. And I do think the federal government has been very upfront that, you know, there's a lot of messaging out there that this was safe. And in fact, this vaccine may be under more scrutiny than any vaccine ever before, but it's still about the confidence in the facts. Which actually gets me to this. This is a great website for the people on the call. If you guys are looking for materials, whether they be training for your social group, your cultural influence, whether it's for social media, this website, Vaccinate with Confidence, has really wonderful stuff on their website. And some of the things that I'm sharing with you today are from that website, such as how can we, as community members, as medical professionals in a number of venues, help promote vaccination. And that's by sharing your story. We all have a story to tell. It's all unique, and it all means something to the people who care about us and who look to us for leadership and advice. So we've got Dr. Fauci here. I think he's a very prominent figure, has been for quite some time. There's an amazing Tyler Perry video. I don't know if you guys have seen it, where he asked the questions that he had around the vaccine on camera so that everybody can see what those questions were. And then he got a vaccine on camera, and which is what we've seen from a lot of different people. But if you're able, if you're willing, sharing your story can make a really big difference. And this actually, I just want to highlight this slide a little bit because it actually goes back to something that Broderick said. These are just a few key messages that I just wanted to emphasize for when we're talking to people. You know, while we don't yet know if the vaccine reduces transmission of SARS-CoV-2, the virus that causes COVID-19, it helps protect you from serious illness and potentially reduces the risk to patients, peers, family, and friends. And then the next bullet point is about the testing. They were tested in diverse adult populations, including communities of color and older adults. And vaccine safety, which I'm going to talk about a little bit later, is being continually monitored moving forward. And then the last one just gets at that first point about the things that we still need to do even after you've been vaccinated.
And so, Dr. Satterwhite, as we're talking about, if you go back to that previous slide, as we're talking about key messages to share, as the different testing has occurred in many of our academic institutions, we'll say right now in Region 7, as that testing and those clinical trials are continuing and are ongoing, share with us how important it is for us to continue to get tested, and whether or not any of the treatments, are they the same, have they changed, or they're improving? These are some of the questions that we get from folks in the community. So what happens now? And
Actually,
I'll be informed about what's happening now.
yeah, so thank you. It's like I planted that question, but I didn't. So testing, so actually I mentioned earlier about the importance of continuing those strategies to keep yourself safe, masking, keeping away from people, avoiding crowds, but testing is a piece of that too. Testing is how you're going to know if you need to, first of all, stay home and make sure you don't get others sick. But and possibly if you need to have a little bit of awareness, if you're developing symptoms, whether you might be eligible for some of the newer treatments. So when COVID-19 first arose, there weren't really great treatments for it. In fact, what doctors were doing was doing the best they could to do what's called supportive care, trying to help people breathe, trying to treat some of the things that were happening to people's bodies when they were developing these symptoms of COVID-19. Since that time, we actually do have some treatments, and probably I would say the one that's most promising is something called monoclonal antibodies. And so that's a drug that you can get. So if you, let's say you're having symptoms, so you go to a health center somewhere or a pharmacy and you get a COVID-19 test, and that test comes back positive and you're having some symptoms, there's a chance that you're eligible for this therapy. And it's called infusion. So you have a needle in your arm and the medicine is put in through that needle. And it's actually pretty effective. Like it can help keep you out of the hospital. So you must continue to be aware of symptoms and go get tested if you're at all worried, because there are things that we can do for people to help keep you safe if you detect that disease earlier in the course of transmission, in the course of development. So it's a really important point. We can't just focus on vaccine. We've got to focus on the other things too. And fighting a disease like COVID-19 is a really multifactorial approach. There's a lot of things we got to do. And how do you keep informed? Well, I love CDC. And I think, there's a lot of media out there. I would encourage you to consider where you're getting your news from and to see if that is a factual source. I would encourage, Facebook is not a great source, but I definitely think CDC is my go-to. A lot of the things I'm sharing on this are from CDC. You can see my link right down there at the bottom of the slide. This is from their Vaccinate with Confidence part of their website. So that's what I would do. I mean, it's a little, and you can watch the news. I mean, I think that a lot of people, you want to get a news source that has a good, reputable site. So that help, Broderick?
That does help. And if I may add one additional site, so I've put it in the chat. So I happen to have the pleasure of serving with Dr. Mario Castro, Dr. Ed Ellebeck, Dr. Alan Greiner, and myself on the rapid acceleration of diagnostics in underserved populations. And we have a team, I've put the link in the chat, that has created a communication tool second to very few. Our local communication team has now been, their information is now posted on the national website. So we have a group of local folks, Dr. Yvonne Chin, Mariana Ramirez, and Dr. Crystal Lumpkins have really put together a pretty all-inclusive website or toolkit of communication material. So you'll have it in English, Spanish, in Vietnamese. You'll see individuals that are local people that are getting vaccine. You'll see local people that are getting tested. And so what we try to do on a weekly basis is to make sure that this website is continually updated so that the folks here in our community and those that want to visit this site have accurate, up-to-date information as it comes out. Because we know COVID could be changing hour to hour, day to day, week to week. And so our communication team is very poised and intentionally trying to make sure that the most up-to-date information is available for our viewers.
I'm so glad you mentioned that, because the other sort of websites and sources that I want to highlight are actually the state health department websites. and even the county health department websites in terms of, you know, availability of testing, availability of vaccines. Those are the places you're going to go. And those messages are also vetted through a public health framework and should be very accurate. So I do want to give a shout out. I know our state and local partners in public health have also tried to make their websites as informative and accurate as possible. All right, so moving on.
Yes, sir. Yes, ma'am.
Awesome. It's totally fine. I love this. So the next two slides I have are from the de Beaumont Foundation, and I wanted to share these because I think we all know, but I just want to emphasize that language matters, words matter. And what the de Beaumont Foundation tried to do was test which words resonated better with people. And so I have a link at the bottom of this to the full one-page PDF file, but I put this up here because so what we're seeing in the blue is words that we should use more, and in the black column is words that we should use less. So instead of saying a vaccine that was developed quickly, we should say it's an effective and safe vaccine because it is. Face masks instead of facial coverings, essential workers instead of frontline workers, personal responsibility instead of national duty. And there's a whole bunch of these. I'm going to actually show you these two. Sorry, I keep moving around. Okay. The benefits of getting vaccine instead of the consequences of not taking it. So, you know, the positives. Getting the vaccine will keep you safe. It's going to protect your family. And then even thinking about using the word vaccination instead of injection or inoculation. And I think we're seeing kind of in the new and popular media, I think people get tired of using the word vaccination. So they use all sort of jabs, pokes, like all sorts of things. But in general, when we're thinking about public health messaging, medical messaging, the word vaccination seems to resonate better than injection and inoculation.
Yeah, because people have fear of needles. I mean, that is just a common fear that a lot of people have. And when they hear anything coming at you with a needle, that automatically creates defense mechanisms for folks. And so we want to be able to use language that individuals are accustomed to seeing and that they're comfortable with. Oftentimes when I'm working with many of my colleagues, both in the community and in the academic arena, we want to make sure that we're using words that people are comfortable with hearing, even though the academic words may be accurate, but if a person doesn't understand it, then they're not going to be able to engage with it. And so we want to make sure that not only are we providing accurate information, but that we're doing it in a way in which we can engage with the public, that we can engage with the residents, that we can engage with those folks that are vulnerable, that we can engage with those folks that are at risk. We want to be able to engage with them to help them have a better understanding.
Yeah, and Broderick, oh, go ahead, Terry.
You go ahead, and then I'll make a comment.
No, mine was a joke.
We need some lightheartedness in
yes, absolutely,
Catherine. So save your joke, but don't forget it. I was just going to say, surely we all agree words matter, language matters, that we can put off people using some sort of words versus some others. I must say that I looked at your two slides in advance, and I wasn't totally persuaded that these words versus those words were necessarily the ones that were going to work in a lot of the communities that I'm familiar with. And so I would guess you probably both agree that this needs to really be particularized, and the takeaway is not use the blue column and not the black column. The takeaway is words matter, and know your community, know the group to whom you're speaking, or the person, the individual to whom you're speaking, and adjust, the conversation so as to gain comprehension and not distance.
And
Terry, I agree.
You're so right. We have often, again, with our health equity task force, we have quite a few community members and community residents that participate. Even on our REDX communication team, we have a lot of community consultants, and we would take this and say, okay, based on here's a foundation. How would you say that we should present this to a particular target audience? So what I would say to a group of students in a college, and what I would say to a group of congregants in a church, to what I would say to a group of individuals that's on the bus stop, to what I would say to a group of individuals at a community center may be totally different in all four of those situations. But you got to get input, feedback from those folks in those situations to allow us to be able to communicate in a way that folks can engage and understand.
Yes, I agree with both of you. And here's my joke. When you were talking about needle fear, I was going to say, I don't think you've met my daughter, but maybe you have, because she has a very real needle fear. And it's actually an important thing to point out. So it's not just maybe even lack of confidence in a vaccine safety or efficacy. Maybe there are other reasons that aren't maybe even specific to this vaccine. So thank you for raising all of those points and for like really putting a punctuation mark on it.
So Dr. Satterwhite, we have a couple of comments in the Q&A.
Yeah.
And I'm just going to read one of them from the good Dr. Jason Glenn. His comment is that in response to religious concerns about the vaccine, it is historically disingenuous to claim that there are religious grounds to refuse the J&J vaccine because it was developed in part by using cell lines from aborted fetal tissue. There are no medical interventions that are morally pure in their development. The entirety of biomedicine rests upon the legacies of exploitation and the abuse of slaves, prisoners, orphans, the mentally disabled, and poor people of color. So to single out one medical intervention is morally impure is ridiculous. That was one comment by one of our viewers. Then our second one is asking, can you recommend a source to learn more about how monoclonal antibodies are created and work within the immune system?
Okay, yes, I can. And I don't, I'm gonna have to Google it really quickly and I can drop it in the chat later. But the answer is yes, there are a couple good sources that I'll send, and I'll drop those in there just as soon as I finish with my slides. It might be at the very end, but I promise I will drop them in there.
And are Catherine, are there, yeah, I don't see the question. Are there some therapies that have been tried that did not work that we should, I mean, that people may not realize didn't work? They got a lot of hype over the last year, and then were rejected because they didn't work. I heard of one just recently.
You want to mention which one that was?
I don't recall right now, but
and I would say, and I'll have to yield to our colleague, Dr. Mario Castro. In one of his presentations, he actually lists, I think a lot of our folks don't realize how many different types of vaccines were in the pipeline, if you will. And I don't have the actual number, but there were a number of vaccines, and I know for sure 2 of them have been stopped because of not being non-effective. And so, yeah, to your point, Terry, there is information out there, and I'll have to grab my the good Dr. Castro's slides and present.
Yeah, I think over 150 or something have been worked on. That's the vaccines, and then the treatments is another thing. There's been a number of things. So, Catherine, if you know something about that and could address that too.
Yes, there are definitely different types of drugs, of therapies that have either been used in the hope that they would work or tested to see if they would work that ultimately have not worked. So I mentioned early on that we really didn't have a lot of good tools to treat COVID-19. So some of the things we sort of had to try just in an attempt to save people's lives. And maybe they didn't make that much of a difference. There ultimately were some drugs that we actually felt like may have done harm, but were withdrawn from the treatment menu once that was revealed. So it's a complicated answer, but the short answer is yes, there are drugs that maybe were used at one point or were even tested, and they do not actually work.
So hydrochloroquine
Yes, that is one of them. Hydrochloroquine is one of them. And then there are some other ones where I think, we kind of see some mixed results on different studies. So I think we'll continue to get more information on how to treat things. So monoclonal antibodies is an interesting story. We thought it would work. So and I say we, meaning the larger medical community, quickly set up studies to evaluate their effectiveness. And when early signs showed that they were effective, they continued to monitor it. And they also created studies that looked at real world use. But even then, we're looking at ways to make them even better. So if we use a monoclonal antibody product with something else, is that even more effective? So there's a lot of work going on in this field. And just like any therapy, some of it's going to work and some of it isn't. And it's even not horribly uncommon that we think something works and later we find out that it doesn't, so we stop using it. That's medical advancement or medical research. And sometimes it can be frustrating, but it's the process that we have to work through with those trusted experts and in concert with the Food and Drug Administration, who very closely watches all these data.
So thank you for that. And there may be somebody in the audience who has additional information about specific therapies that have been tried and abandoned. If you could post that, that would be great. But let's go back to Dr. Glenn's comment, which is really important. And both of you, comments in regard to that?
I'm going to let Broderick take that one, just because I think that there have been, and I will, the only thing I'll say is, so specific to the vaccine, the Advisory Committee on Immunization Practices has certainly released things like the ingredients of vaccines and has also looked at things about the development and does have some language around that. But I'm going to pass it to Broderick for more of a comment on Jason's comment.
Well, and I think he makes a good point. Whether folks agree or disagree with him, the point that he's making is very valid. There is no medical interventions that are more morally pure in their development. I often share with folks that, when oftentimes people feel a certain way about clinical trials and testing medicines for a number of different reasons. As Dr. Clinton indicated, a lot of the therapies, a lot of the procedures that we have in practice today, I mentioned J. Marion Sims earlier in my comments. Well, he was known as the father of gynecology, but yet most of his practices were done, if not all, in enslaved women. So here you have practices that are currently being used that were done and perfected on enslaved women, but that therapy is okay. You see what I'm saying? And so when we really need to take a step back and look, is it good? Is it best for the common good of our citizens in this country? Too often, I think we allow beliefs and opinion to sway individuals one way or the other. And I don't think that it's appropriate to sway individuals. Allow individuals to get their own data, allow individuals to do their own research, and allow individuals to develop their own responses to the facts and not be swayed by a political group, by a religious group, or any other group. I don't believe that's their place. I think that where it should occur is with an individual, like again, I mentioned 6 brothers and sisters. I will give them the facts. I will share with them my level and where I'm at, but I'm not going to try to sway them. I'm just going to give them the facts and then let them make their own decisions for themselves and their families. That's the way it should be.
Thank you. Catherine, do you want to proceed, and then we'll come back to some more Q&A?
Sure. I'm actually going to now move into a little bit more of a little bit more data, a little bit more science around specifically safety, but I'm also going to mention, just sort of summarize how vaccine distribution from the federal level is working. Hopefully, there we go. So starting with the vaccine distribution. So it seems like it's been many, many years since the first vaccine came out, but it really wasn't that long ago, mid-December. So since mid-December and through today, what's happening is the federal government is making allocations to states. And then states are distributing that vaccine to COVID-19 vaccine providers. So those are individuals or hospitals or practices that have signed up with the state to be a provider and agreed to follow certain rules around data reporting and even around administration, such as not charging for the vaccine. Then the federal pharmacy partnerships came on board. The first one was directed at long-term care facilities, so nursing homes, and CVS and Walgreens were the main pharmacies who worked in that area. They would go on site to nursing homes 3 times per facility and vaccinate their residents and staff. Again, it was free, and this program is actually wrapping up. We do know that there's going to be an ongoing need to support populations of people in these long-term care facilities. So there are a bunch of different options as to how states can help support the ongoing, if somebody enters into a nursing home or there's a new staff member, things like that. The program that's really sort of ramping up right now is the retail locations pharmacy, which I'm going to just share a little bit about right now. So that is the federal government working with states and working with 21 national pharmacy groups. And I'm going to give you the very high level, but there is a website here if you want to go for more information. And they are vaccinating priority groups at no cost. And just on Tuesday, I was like, man, good thing I didn't send my slides yet. The Biden administration did announce that all pharmacies participating in the federal retail pharmacy program were going to focus on getting educators and staff in pre-K to 12 settings, along with child care workers. So they were going to prioritize that group. They weren't going to cancel any appointments that had already been made, but really work in that group with the idea that every eligible person can get an educator and staff and child care worker get their first dose by the end of March. So that's been a very new thing. Then this is a phased implementation, so it's definitely not fully rolled out yet. I think they're in 7,000 pharmacies right now, but ultimately it'll be more than 40,000 pharmacies. And this is really important. This vaccine supply is actually being provided on top of the state allocation. So the federal government is really using this program, as well as the next program that I'm going to describe, to supplement state efforts. And we think about equity, it's something that we talk about a lot, certainly across all public health and medicine. It's really one of the Biden administration's focuses is to reopen schools. So the emphasis on teachers is really aimed at getting every child back into school. So then the next program I want to share, and this is really new, it's only a few weeks old, is actually looking at health centers. So these are called federally qualified health centers. And that's where this program is focusing on. It is, again, a partnership with the federal government through the Health Resources and Service Administration, it's called HRSA, and CDC, and again, working with states. And what's happening is the health centers are vaccinating priority groups again at no cost. Again, that's very important through all these vaccine programs. And they're doing it according to state plans. So if the state says we're vaccinating 65 and up, health centers are vaccinating 65 and up. This program is really designed to address vulnerable populations, because a lot of these health centers are located geographically to disproportionately affected populations. And these were sort of the 4 criteria that were used to select initial health centers to participate in this program: individuals experiencing homelessness, public housing residents, migrant or seasonal agricultural workers, or patients with limited English proficiency. I think this program has been fairly well received, and we've just heard that it's going to continue for at least 6 months, with more and more health centers added into this program moving forward. Again, there's a link if you need to know, or if you're interested in learning more.
So Dr.
So any comments? Yeah, go ahead.
Yeah, if I could jump in here, if you go back one slide. And so a couple of things that has been troubling for those of us that are working with the Wyandotte County Health Equity Task Force and with RADAC. And so it is uncomfortable for us to be doing the work that we're doing, particularly in at-risk communities, and the health departments not be aware of where these vaccines are going. So for example, because of the series of meetings that we have during the course of the week and the members of community, we have learned through members of community that the hen house on state is providing vaccines, that medicine shop is providing vaccines, the CVS. And so it is troubling that certainly we want the vaccines to get to every hand and in every arm that it can. But for us to be able to try to help inform our community when the health department is not being kept apprised of where these vaccines are going, and we have to find out by word of mouth, that's a little troubling. And then okay, go ahead. You want to respond to that?
Well, actually, I do want to respond to that because I think it's a really good point. I think we've continually struggled with making sure lines of communication are as clear as possible. Having said that, it's been particularly challenging, I feel like right now, to understand vaccine availability and where you can go and get a vaccine. I think it's one of the most common questions that people ask, where can I get a vaccine? In this atmosphere of limited supply and high demand, it has been more of a patchwork system than we would like. States are, so the federal government is trying to communicate to states, they're trying to get to local health department. It is not without bumps. I do think that it will get better in the future. There is a website called Vaccine Finder that the federal government will host that should be more of a one-stop shop to understand what vaccine you have available. You can search by zip code. Iowa is the pilot for Region 7, but we hope that it'll roll out to all states pretty soon. But it is a very real thing. And I hear you. So.
Yep, no problem. And this is why, again, we're having a conversation, as you said. So my second comment is as it relates to the FQHCs. Certainly within Region 7, there are multiple urban communities that have large FQHCs. To my knowledge, as of yesterday, none of our FQHCs here in the greater metropolitan area has received them, and very few within either state of Kansas or Missouri. So how can the public be assured that those vaccines are going to get to the FQHCs that are on the viewer, that the viewers on this call represent?
Yeah, no, it's a good question again. I mean, all your questions are good. So I can tell you so this program that I'm talking about here is a federal program. Similar to the retail pharmacy program, this is allocation on top of what states are already doing. So states have also been sending vaccines directly to pharmacies and to health centers. So we actually have, and we do actually have a number in the Kansas City area, for instance, I just happen to be aware of that, of health centers who have gotten direct vaccine from the state. They aren't necessarily yet part of the federal program, but they have gotten it from the state. And actually FQHCs, I was talking to Nebraska yesterday, and they are really looking at ramping up their allocations directly to health centers because they play such an important role in our community and they have such an important population. And again, getting at that trusted resource. They are a trusted resource for people who may not have other resources to seek healthcare. So they have been used, they are being used. I think they're only going to be used more. And to get to your second part of that question about the Vaccine Finder, and that is going to be one of the reasons that we've been really cautious in rolling that out is we want to make sure it's right. We really don't want people to go to places that say they have vaccine and then get there and there's no vaccine. So it's about the reporting and really straightening out the reporting mechanism.
Okay. Well, as quickly as possible, and of course, we'll continue to have conversations, but I think it's important for those of us who want to try to help the underserved populations, particularly those zip codes that have had or at a higher vulnerability rate or that are at greater risk. We want to make sure that we have information that is to assist them to be successful in getting the vaccine. So Dr. Rosell, I know we only got a few minutes left, but there are a couple of other questions in the Q&A that I think we ought to address. The first one, if you don't mind, is will people be able to choose or defer until the vaccine manufacturer of choice is available? I'm also hearing a lot of frustration with the J&J vaccine due to the baby powder scandal or baby powder scandal, and that J&J will be forced upon them due to one dose being more efficient to distribute. Dr. Satterwhite, how would you respond to that?
I'm actually going to respond to this and wrap this into the next comment too from Ruth Ramsey,
Okay.
who's asking about should different people in a household get different vaccines? And the answer resoundingly across all public health officials is you should get the vaccine that you have available to you. However, I understand that some people may not want that. So, you know, if you feel passionately that you don't want one vaccine or you prefer another, then the reality is you're going to have to wait, because right now the supply is so limited. We're trying to really get that out to as many places and people as possible. And from what I'm hearing, people are taking the Johnson & Johnson vaccine and just integrating it into their overall approach for distribution. So, you know, the Advisory Committee on Immunization Practices, so that's the CDC group that CDC runs that makes recommendations, does not have any preference for vaccines. They don't say one is better than the other. They are different. Certainly one is one dose and two are two doses. And I think this is something that I will continue to message. It's good to have questions. I also encourage people, get the vaccine that you are offered. So.
And that is exactly what we have done from both the RADx perspective and our Health Equity Task Force, is that we may not have the option of deferring one vaccine to another. The best vaccine is the one that you can get in your arm today. And so we're encouraging whatever vaccine is available, that's the one you want to get. If you want to defer, again, as you stated, you may have to wait.
There are a couple of resources from listeners too. Thomas suggested a good general reader source on the immune system is An Elegant Defense by Matt Richtel, spelled R-I-C-H-T-E-L. Jason mentions 4 other therapies that were tried and didn't work out so well: losartan, selinexor, remdesivir, and tocilizumab.
So Terry, I'm glad you pronounced all of those, because
I didn't do it correctly, I'm sure, but they all turned out not to work well, Jason says. And I think you have a couple more slides, Catherine.
I do, and I'm just going to zip through them if that's okay, because I want to make sure that I specifically emphasize this one. So I mentioned safety. So when the Food and Drug Administration, the FDA, reviewed these vaccines, they looked at safety data that had been collected as part of the research trials to test the efficacy. They are also looking at safety after the vaccine is in use. So what you see here is after a month, what we see here is very similar safety profile as what was reported in the trials, which is great. That's showing that it's mirroring, that the trials are actually mirroring what is happening in the real world. And to highlight here, I want to say, so the most common for your first dose, if you're getting one of these 2-dose vaccines, you might feel a little bit of pain in your arm. And then we do know, and you probably have heard about it from people who either gotten the vaccine, you've probably seen about it in the media, we do see a little bit more what we call reactogenicity after that second dose, when you might actually feel kind of crappy. You might actually get a little bit of a fever. You might feel tired, and you might need to kind of chill out in bed for a day. So if that happens, that's normal. If it doesn't happen, it doesn't mean the vaccine didn't work. So either way, it's normal. And then the other thing I'm going to share, this is, I just have these few last slides, is that I just wanted to highlight this whole thing about our wait and see. If you remember, I showed you that vaccine confidence and uptake is on a continuum. So this shows that when we looked at this nursing home program, this long-term care facility program, 77.8% of residents and 37.5% of staff members received their first dose. So what you see here, so darker is the residents on the left, and that a much higher proportion of residents were willing to get their first vaccine than staff members. So this staff members only getting, like if we look at Kansas, more than 80% of residents got their first shot, but in compared to staff, less than 40%. So this is a population, what we've heard is that they wanted to wait and see. It's not that they never wanted it, they wanted to wait and see. So I just rushed through that. That's just a bonus slide. Essentially, that's it. And I'll turn it back over to you guys.
Dr.
Satterwhite, yeah, I was going to say it's been a pleasure just having a conversation with you today. I want to reemphasize what you were saying about possible side effects or adverse effects. It is going to be different for every individual. I will tell you, after my second dose, I was down for a day, the next day. But amazingly, that next morning, it was as if nothing happened. It was just uncanny how that happened. But then I know others that had zero effects, nothing at all. So it is absolutely going to differ person to person, but just know that there is the chance that you may have some adverse effects or side effects, but it will pass. In my case, in 24 hours. And in most of the folks that I know that have had them, they were gone in 24 hours. So it wasn't something that lingered multiple days. It was a one-day deal and then you ready to go. Dr. Rosell, again, thank you and the Center for Bioethics for having us today. I think this has been a very engaging and certainly very enjoyable conversation with Dr. Satterwhite.
And
likewise.
I want to thank both of you on behalf of the Center for Practical Bioethics. We appreciate the contributions that each of you make on a daily basis to the community on behalf of us all, and then particularly for this hour with us. Matthew, do you have a final comment or announcement?
Sure. I hope you can hear me okay. I had some slight technical difficulties earlier and I'm not
We're
going to be
hearing
able
you.
to,
Yeah,
no camera. So as we sign off, I just want to remind everyone that that these sessions are recorded and they're posted to our YouTube channel. So you can go to YouTube and search Practical Bioethics to find our channel there. You'll find this episode as well as the other episodes in this series and other COVID and bioethics related content there. And then check out the American Public Square website for information about the upcoming or the next episode in this season. That's going to be on April 1st. That information is also going to be on our website as well, on our events calendar. And then also sign up for the March 12th Cultivating Compassion and Mindfulness workshop with Dr. Barry Curzon, which is, again, March 12th, a week from today. So with that, I just want to thank everyone for being with us today. Apologize for any technical difficulties. I think everything went off okay, but I think it was just on my end. So I'm hoping that the recording and everything comes out all right. So thanks to everyone, and thanks to our speakers, and thank you to Terry. And we will see you on the next one.
Thank you so much. Take care all.
Bye-bye.